Okay. Who did we decide was going first?
Mohammed is going to go first.
Mohammed. Okay, great. Well, I have the pleasure of introducing Mohammed Andalibi. He will tell you his full name at the beginning of his talk because it's a little more complicated than I just gave you. But Mohammed is a physician and currently here with me in San Diego as a postdoctoral research fellow. And he's been looking at biomarker associations with cognitive impairment and neuropathy, and also took on the daunting task of basically starting from scratch and learning about how to do microbiome analyses. So he's been working with Rob Knight and our very large microbiome group here at UCSD. In any case, he's going to tell us today about a problem that I consider to be still a significant issue, which is distal sensory polyneuropathy in people with HIV. And he will tell you more about that. Thank you, Mohammed.
Thank you, Dr. Ellis. Hello, everyone. My full name is Mohammadsobhan Sheikh Andalibi, but yeah, you can call me Mohammed. And I'm so delighted to share one of my projects, to present one of my projects today with you, which is about the inflammatory biomarkers, the association of inflammatory biomarkers and distal sensory polyneuropathy in people with HIV. Let me share my screen. Can you see my screen?
Yes.
Yeah. Okay. In addition to depression, cognitive impairment, distal sensory polyneuropathy is one of the major complications experienced by people with HIV, even in who are virally suppressed. This type of peripheral neuropathy causes symptoms such as neuropathic pain, paresthesia, and loss of sensation, which can significantly impact the quality of life of people with HIV. And we all know that HIV is associated with hyperinflammatory status and immune dysregulation, which leading to endothelial dysfunction and microvascular injury that can result in insufficient blood flow and ischemia that may contribute to the nerve damage and dysfunction and immune and neuro inflammatory states or disorders. And the role of inflammation in HIV is partly understood, but relatively unexplored as regards distal sensory polyneuropathy. So in this study, we wanted to determine whether DSP signs and symptoms were associated with an extensive panel of targeted plasma biomarkers. This panel contains 15 biomarkers, plasma biomarkers, which are D-dimer, intracellular adhesion molecule, and interferon gamma induced protein 10, interleukin 6, interleukin 8, MCP1, MMP2, MMP7, soluble CD14, soluble TNF receptor-II, tissue inhibitor of metalloproteinase 1, and TIMP2 or tissue inhibitor of metalloproteinase 2, urokinase type plasminogen activator, vascular cell adhesion molecule, and vascular endothelial growth factor. And in addition to that, our secondary objective was to determine whether the possible association differed between people with HIV and people without, and also whether the plasma biomarkers mediate the association or influence of HIV status on DSP symptoms, including dysesthesia or neuropathic pain, paresthesia or tingling, and loss of sensation. It is worth mentioning that in clinic, signs is the disease condition that physician or examiner perceive that, and symptoms are the disease conditions or any abnormal findings that patient report subjectively. And also, we defined DSP or distal sensory polyneuropathy as having two or more than two signs, which are bilateral distal vibration, sharp and touch loss, and also ankle reflex loss. So if any patient had two or more or three sign out of these three signs, we categorize them into DSP, to having DSP. So as we observe in the table, the majority of our participants were middle-aged, and people with HIV had significantly more men than people without. More than 80% of people with HIV were virally suppressed and on antiretroviral therapy. And the history of diabetes was pretty similar between people with HIV and people without. And also the metabolic syndrome, the frequency of metabolic syndrome were pretty similar between two groups. But the frequency of lifetime methamphetamine use disorder was 2 times higher in people with HIV than people without. In terms of DSP and its symptoms, the frequency of DSP was 3 times higher in people with HIV than people without. And in terms of DSP symptoms, the DSP symptoms were 3 to 8 times more in people with HIV than people without. So, in order to reduce dimensionality, we did factor analysis, which yielded on 6 factors. Factor 1 loaded on MCP1, TIMP1, IP10, IL8, VEGF. Factor 2 loaded on VCAM and soluble TNF receptor-II, TNF receptor-II. Factor 3 loaded on UPAR, D-dimer, and IL6. Factor 4 loaded on MMP2. Factor 5 loaded on TIMP. And factor 6 loaded on MMP7. And in order to identify the determinants of DSP and its symptoms, we ran uni and multivariable logistic regression. So we adjusted our model for extensive set of confounding factors, demographic and clinical confounding factors, including age, sex, ethnicity, height, diagnosis of diabetes mellitus and metabolic syndrome, HIV status, from income, cardiovascular risk score, lifetime alcohol, methamphetamine, and opioid use disorder. After adjusting for these confounding factors, we found that DSP was associated with factor 4. I mean, factor 4, increasing factor 4 was associated with about 5-fold higher risk of DSP. And also HIV seropositivity was associated with DSP. In terms of loss of sensation, factor 2, which loaded on VCAM and soluble TNFR2, was associated with 2-fold higher risk of loss of sensation, which is one of the symptoms of DSP. And also, as we expected, HIV seropositivity was also independently associated with DSP and loss of sensation. So, since HIV was one of the independent determinants of DSP and its symptoms, we split our data set into HIV positive and HIV negative people, and reran the multivariable logistic regression. So in people with HIV, factor 2, which is VCAM and soluble TNFR receptor 2, was independently associated with a 5-fold higher odds of DSP, and loss of sensation, distal bilateral, distal bilateral loss of sensation was associated with 2-fold higher odds of was associated with it in people with HIV. Factor 2 was associated with a 2-fold higher odds for loss of sensation. So that seems interesting to me, because after we adjusted for extensive set of confounding factor, as I mentioned you, and in addition to, and we also add additional confounding factors such as duration of ART, duration of HIV infection, plasma viral load, current CD4 T cells. We also did observe that factor 2 was associated with DSP and loss of sensation. In people without HIV, after adjusting for confounding factors, we did observe that increasing in MMP2 or factor 4 was associated with increasing risk of DSP. And for factor 2, there was a borderline p-value for increasing risk of tingling or paresthesia after adjusting for confounding factors. So, since there was a significant interaction between HIV and DSP, and factor 2, we try to figure out whether factor 2 mediates the influence of HIV and DSP symptoms. And we ran the mediation analysis. And in this test, the indirect effect measure how factor 2 loading inflammatory biomarkers mediated the relation between HIV serostatus and DSP signs and symptoms. So as you can see in these figures, this result shows that both the direct and indirect effects of the HIV on DSP were significant via the mediator. The indirect effect of HIV on DSP were mediated by the factor II, and the proportion of mediation was were between 18 to 20%. So we did observe that factor II mediates the relationship, the association between the HIV and DSP and its symptoms, such as loss of sensation. So this study had significant clinical implication because symptoms are the main reason that patient seek medical attention. And since we did causal pathway analysis or mediation analysis, we observed that increased inflammation and endothelial injury, which is mediated through the soluble TNFR2 and V can contribute to distal sensory polyneuropathy and its symptoms, such as loss of sensation and paresthesia, both by mediating the effect of HIV and DSP and by independently affecting loss of sensation. And based on the literature and the previous study, paresthesia is known to be a predictor of future neuropathic pain in people with HIV with DSP. And it is worth mentioning that DSP is associated with lower quality of life, reduced daily functioning, cognitive impairment, or depression, even depression, and balance problems, and preventing or alleviating it might improve the quality of life of people with HIV. And this study implies the plausible utility of interventions directed toward modulating inflammatory biomarkers, thereby attenuating the propensity for DSP in the HIV-infected population. So, in summary, the result of this study suggests that the pathophysiology of DSP may differ in people with HIV and people without HIV through endothelial dysfunction and cell signaling, intercellular or extracellular signaling pathway. And understanding these interactions between HIV, biomarkers, and DSP could help us to, elucidate and understand better the mechanism underlying the association between HIV, inflammatory biomarkers, and DSP. And for future study, we can suggest that the future study should examine the role of inflammatory biomarkers, both plasma and CSF biomarkers, and as well as adhesion molecule in DSP development among HIV patients. This could broaden the understanding of DSP and lead to discovery and developing of new therapeutic targets. And since neuropathy is one of the main concerns and one of the main consequences of HIV, it might be advisable to administer some medication that can effectively suppress inflammation and endothelial dysfunction in these patients. I would like to express my appreciation to my supervisor, Dr. Ronald Ellis, and HNRP investigators, including but not limited to Dr. Robert Heaton, Dr. Letender, Dr. Udicello, Dr. Fields, Dr. Tang, Dr. Azin Tavasoli, and Donald Franklin, and other HNRP team, and the HNRP team. Thank you. Any question?
Do we have any questions?
Yeah, hi,
Dr.
this is-
Ellis, I don't know if you want to facilitate questions.
Hi, this
Yeah.
is
Go ahead, Pim.
yeah,
I
this
think
is Pim. So I had a question about your factor analysis. So when you did that, the factors that you have there, is that on the basis of a rotation, or is this just the first outcome? And is the number one factor the factor with the largest amount of variance explained and so forth downwards?
I use the rotation method,
Okay.
and yeah, and what was your second question? Excuse
No,
me.
whether you display them in terms of the highest amount of variance explained and then less variance explained, etc.
Oh, I think it was on highest variance.
Okay, perfect. And the
Yeah.
second question I had was for your factor 2, did you also try to correlate, the scores on factor 2 with some of the demographic variables? For example, do you have a higher score there for older people or people with lower viral loads or something like that?
That is a very good and interesting question, and I think I should do that in the future. Unfortunately, we didn't do that, but I think we should do that in the future.
and it could be added to the manuscript. But you
Yeah.
did include those confounders in the multivariable regression, so it's control for that.
Yeah.
I suspect that Pim is right about the age effect.
Yeah, and also we check for the collinearity. So if there was any potential correlation between the factors, we could find out.
Okay, so that raises then one more question. Was your rotation orthogonal or was it oblique? If you
It
know.
was orthogonal.
Okay, so there
Yeah.
should be really no correlation between the factors.
Yeah.
I'm not seeing any other hands, but I think Mohammed would be happy to receive additional questions through the chat or by email. And just let us know if, Mohammed, why don't you put your email address in the chat there so people
Yeah, I
can
will.
contact you.
Sure.
Okay, well, thank you. And are we, Cassidy, ready for Azin?
Yes, Azin, are you ready?
Yes.
Great, okay.
So Azin is also a physician and got her degree in 2018. She's been with us for over a year. And she actually came to San Diego in April of this year, but I've been working with her for longer than that remotely. So she has been interested in research on neuropathy and other complications of HIV, neurologic complications throughout her research career. And most recently, she's interested in the relationship between HIV and comorbidities, particularly the question of whether people who are cognitively impaired have potentially poorer adherence to their antihypertensive and anti-diabetic medications, and therefore don't control their disease well and have complications of their comorbidities, which is a big issue in HIV these days. She's not going to talk about that research today, but perhaps in the near future, pretty far along in that. But today she's going to talk about inflammation and neurodegeneration. There's a lot of cross-sectional evidence, but what Azin did was look at longitudinal changes in inflammation and neurodegeneration. So a little bit closer to getting at some causal relationships. And she will talk today about that research, which, correct me if I'm wrong, Azin, but I think you've had a abstract accepted for CROI. And so congratulations to Azin. And why don't you go ahead?
Well, thank you, Dr. Ellis, for introduction. Let me share my screen. Okay, today I'm going to present our most recent publication, Increasing Neuroinflammation, relates to increasing neurodegeneration in people with HIV. HIV enters the brain early in the disease, and infected monocytes and T cells can activate macroglia, and these activate macroglia can release pro-inflammatory cytokines such as TNF-alpha, interleukin-6, and other biomarkers, and also monocyte-derived cytokines can activate astrocytes. These activated astrocytes and microglia can release inflammatory biomarker that can cause neuronal injury, which can drive neurodegeneration in people with HIV. We know that ART can help people to have a longer life, but their neurons can expose more to inflammation that can contribute to neurodegeneration. And high levels of macrophage activation markers such as CD14 and also CRP, interleukin-6, TNF-alpha, and neopterin have been linked to cognitive decline. And also we have a neopterin, that is a production of monocyte cells that some studies found that it can be related to reactive oxygen species that might be relevant to neurodegeneration in people with HIV. So aging with HIV infection can cause neuroinflammation and immune activation, systemic inflammation and immune activation, which can drive neurodegeneration. There are several cross-sectional studies that found that change in CNS and systemic inflammation can cause neurodegeneration. But we want to know that do longitudinal changes of these biomarkers can cause neurodegeneration. So we hypothesize that increasing inflammatory biomarkers might be correlated with increasing biomarker of neurodegeneration. And we also predicted that viral suppression between the baseline and follow-up visit is associated with decrease in marker of neuroinflammation and systemic inflammation. We had 108 people with HIV in Charter Aging Project, and we included participants if they had plasma HIV RNA lower than 50 copies at their follow-up visit, and we excluded participants with severely confounding medical and neuropsychiatric disorders. And we collected the CSF and plasma samples at baseline and 12-year visits. We had a panel of 14 soluble biomarkers. We had CRP, CD40, and D-dimer in only plasma. And we had neurodegenerative biomarkers like NFL or neurofilament light, total tau, amyloid precursor alpha, amyloid beta 42, and phosphorylated tau only in CSF. We had interleukin 6, soluble TNF alpha receptor-II, and ATOX-DG, neopterin, MCP1, or monocyte chemoactin protein 1, and CD14 in both plasma and CSF. We calculated changes in each of these biomarkers from baseline to 12-year visit. And we did factor analysis to construct simplified indices of biomarker of systemic inflammation, which were plasma TNFR2, neopterin, MCP1, CD14, CD40, CRP, D-dimer, and interleukin 6. And for neuroinflammation factors, we had CSF STNFR2, CSF neopterin, MCP1, CD14, and interleukin 6. And for neurodegeneration factors, we had CSF NFL, total tau, p-tau, APP alpha, A-beta 42, and ATOX-DG. And then we examined the correlation of changes in systemic and neuroinflammatory factors with change in neurodegeneration factors. And since chronic HIV replication can contribute to persistent inflammation, we divided participants into two groups, became suppressed and remain suppressed. As you can see in this table, in group of became suppressed, we had 53, that 28 of these 53 participants were not on ART at their baseline visit. And we had 55 remain suppressed participants. And the proportion of female was higher on group of who remain suppressed. And current CD4 nadir was the same in both groups. And we had 109 CD4 nadir in group of became suppressed and 67 in group of remain suppressed. For factor analysis, for plasma immune factor analysis, we had factor 1 CRP D-dimer neopterin, factor 2 STNFR2, and for CSF immune factor analysis, we had factor 1 STNFR2 and neopterin, and factor 2 MCP1, CD14, and interleukin 6. And for neurodegeneration factor analysis in CSF, we had factor 1 p-tau and A-beta 42, and factor 2 CSF NFL. As you can see in this figure, we found that higher factor 1 or change in CSF STNFR2 and neopterin associated with higher factor 2 or change in CSF NFL. And because viral suppression is an important determinant of inflammation, we examined the interaction of viral suppression and factor 1. And this in a multivariable model, we saw that the interaction trends towards significance, and the main effect of factor 1 was significant, but the main effect of viral suppression was not. And surprisingly, for those who remain suppressed, factor 1 or change in CSF STNFR2 and neopterin the correlation was much stronger than in people who became suppressed. And in this figure, we found that in people who became suppressed, we had decrease in factor 1 or change in CSF STNFR2 and neopterin, because people who became suppressed, they had higher levels of neopterin at their baseline visit, but after ART treatment, their neopterin levels decreased at their follow-up visit. Because of this, we saw this pattern in people who became suppressed, not remain suppressed. For the effect of age, we found that older age was associated with higher levels of many inflammatory biomarkers, especially CSF, SCNFR2, at baseline visit. And also, older age was associated with neurodegeneration biomarker like CSF NFL at the baseline visit, but we did not see this correlation of age and biomarkers at change of these biomarkers. Also, sex, ethnicity, and BMI did not significantly influence any of the inflammatory and neurodegeneration biomarkers. And we couldn't see any relationship between ART regimen type and any of these inflammatory and neurodegeneration factors. We also found that increasing plasma immune factor 1 or CRP, D-dimer, and neopterin correlated with increasing CSF NFL, and for CSF immune factor 1 or changing SCNFR2 and neopterin was not related to any other neurodegeneration biomarkers like T-tau, p-tau, APP alpha, or ATAXA-DG. So we can conclude that increase in biomarkers of systemic and neuroinflammation can be associated with increase in biomarkers of neurodegeneration, and successful treatment of neuroinflammation like TNF-alpha inhibitors might slow or reverse neurodegeneration in people with HIV. And I want to thank my other co-authors, Dr. Gelman, Dr. Mara, Dr. Clifford, Dr. Udicello, Dr. Rubin, Dr. Latender, Dr. Tang, and my supervisor, Dr. Ellis. And thanks for all HRC and charter participants, and thank you for your attention.
Raha, do you want to unmute yourself? Oh, sorry.
Hi. Yeah, Raha, go ahead. I saw your question in the chat.
Oh, sure. Just Pim got me thinking about this with his last set of questions. So in this case, when you were looking at change, I just wanted to clarify if the factor analysis was done on the change values of the immune markers, or if you calculated the factors and then measured if you did the subtraction between the two time points.
So we first calculated the changes of biomarkers between baseline and follow-up, and then we did factor analysis.
Okay. Thank you.
Hi, Azin. I have one question. This is Santosh from Tennessee. So question is about, you also show like tau phosphorylation and beta amyloid. Can you remind me, was there any changes with the factor 1, and also whether there were any Alzheimer's related tests were done on neurocognitive or behavior decline?
Mm-hmm. Yes, we couldn't find any correlation between neuroinflammatory biomarkers like SCNFR2 and neopterin with A-beta 42 or APP alpha. And for your second question, yeah, thank you for your question, because Dr. Ellis and other charter colleagues, they found that participants with higher CRP, interleukin-6, and CD40 had greater neurocognitive decline over 12 years. And we also want to see the relation between all these biomarkers and other BDI, for example, BDI and GBS in our future plan.
Okay.
Thank you very much.
I see Pim's hand up.
Yeah, so a little bit probably related to Kumar's question. So currently you were correlating the change in your biomarkers with the change in your neurodegeneration. Did you also try to see whether you could predict the amount of neurodegeneration on the basis of your baseline values in these other markers?
I think it's a great question, but I don't think we did it. No.
I think
Okay.
we may have actually looked at it, but I don't remember the result. Maybe you
Yeah.
could go back and look at that again and send Pim an answer. I don't immediately see other questions. So let's see. Cassidy, what do you think? Should we let people go back to their grant writing?
Yeah, if there's no
on,
more
Alice.
questions, I think we can end a little bit early. Azin and Mohammed both put their email addresses in the chat if you want to take those down in case you have any additional questions. If not, we will see you next week. And Len Jordan, Kelly Jordan Shudo, sorry, will be presenting genetic variation in the gene encoding, ER stress, kinase, perk, reveal, altered stress, tolerance in neurons and glia, potential contributor to HIV-associated CNS changes. So
And
we'll
thank
see you
you-
all next
And
week.
thank you, Ron Ellis,
Yes,
for
thank you so much.
introductions and for leading today.
You
Yeah.
bet. My
All right, I'll
pleasure.
see
Have
ya-
a great
I'll see
week.
ya at one,
Happy
Ron.
grant writing.
Bye.